already we're testing more by far than any country.
When we hear statements like we've tested way more people than any other countries, it's important to remember what is the size of your population relative to the amount of tests that you've done. While it's factually accurate to say that with over 4 million tests, we've done way more than many other countries, we also have more people than a lot of other countries. So when you look at what percentage of the population we've covered, we're a little over 1%. And that's not actually very good at all. So that's equivalent to saying, let's test the cities of Philadelphia and Phoenix. And then based on what all of those tests show, we know what's going on in the country. So 1% or 1 to 2% is not good enough to really know if it's safe to reopen the country. We're doing about 150,000 tests per day, plus or minus. And most experts think that at the minimum, we need to be doing 500,000 per day. And the reason why that's important is because when we do open up the country, open up the economy and have more people in closer proximity, we need to be able to aggressively test people who have symptoms so that we can find out if they have COVID or not and socially isolate them or quarantine them so that they're not passing on infections to other community members and do contact tracing and make sure that they're not spreading. And we really can't do that if we can't reliably get a test on the spot for those patients who may have contribute to a second peak, so to speak. Yeah, right now it's the swab test and the antibody test. As far as I know, we don't have a test that's widely available right now. We expect it'll be in the next 1 or 2 weeks. It'll be important to make sure that we validate the tests and make sure that they perform really well. And then if that does work, then that can become what's called our gold standard, meaning that's how we can ultimately tell if you have or have had COVID disease. And then we can get a better sense of how well our swabs are working. And more importantly, how prevalent has it been in the community that we're testing. Because I think if you test the community and about 40% of people, or 4 out of 10, had COVID disease versus only 5% had COVID disease, or 5 out of 100, then you may manage things a little bit differently when you want to reopen the economy. Because in one instance, there may be more people that have been exposed and would theoretically have a lower risk of having a disease if they got exposed again. So there is some difficulty in trying to test people without symptoms. So when you do not have symptoms, even if you are infected with COVID, there's a less likelihood that your throat, which is where we swab from, will have the virus actually there, which is also good because it means less likely to spread infection, though we also know that you can spread if you don't have symptoms. But what we don't want to do is fall into a trap where we test someone who doesn't have symptoms, so they're unlikely to be positive anyway. And then we tell that person, you're fine, you're not infected. That person will later actually have symptoms, even up to 10 or 14 days after initially getting infected. And then, later on have COVID disease and, think that they were negative because they got swabbed before. And that's why this conversation about doing blood tests is actually really important, because we can actually detect if you've had an immune response to COVID disease. People who've had COVID before and have recovered and they're out of that range where they're not going to be positive if we swab them, they may have a positive blood test, and then we can know this person probably had COVID. I work at an academic medical center, and we've been able to stand up our own in-house testing. And that's been really important because that means we have the equipment here to be able to do our tests. And our turnaround time, meaning the time from when we swab the test and when we get the result back, is only a few hours. But there are a lot of hospitals and healthcare entities that are facing that bottleneck because they aren't able to stand up in-house testing. So the CDC and then state public health agencies are doing testing as well, along with private labs. So there is a loose network of entities that can do COVID testing, but they're all associated with their different turnaround time. So I want the ability, whether it's an urban county or a rural county, to be able to do a test on the spot, no matter where that patient is, that same day, that has a rapid turnaround time so that we can do testing and tracing and isolation. That's one requirement. The second is that we really need to see a decrease in the rate and rise of our cases. So the percentage of cases is kind of what we're looking at in a doubling time. That needs to have gone down, and we need to demonstrate that our cases, even though they may still be, happening, that they're not happening at the rate that they were before. In other words, we've seen the peak of the curve, and we're starting to come down. What we absolutely don't want to do is open up the state or the country. We're still in the midst of a peak, and then we just add more cases on top of that. That is a recipe for disaster, and that is a situation where everyone gets poor care, regardless of if you have COVID or if you come in for a heart attack or a broken ankle. You're going to get less care if your hospital system is overwhelmed, and that's not going to be a good outcome for anybody.